is my pleasure to introduce our panelists today. We have Dr. Alicia Haushalter, who is the director of the Shelby County Health Department, and she is also a professor at the University of Tennessee School of Nursing, and also with Baptist College of Health Sciences, and was recently elected to be president of the Tennessee Public Health Association. So welcome, Dr. Haushalter. And we have Ruth Ann Norton, who is the president and CEO of the Green and Healthy Homes Initiative out of Baltimore. It's a national organization that has been on the forefront of eliminating lead poisoning among children. She's reduced, through her efforts and her team, lead poisoning among children in Maryland by 98%, which is pretty amazing. She's helped write over 30 pieces of legislation for healthy housing, and is really a national trailblazer in terms of helping organizations and healthcare organizations form partnerships to improve health through housing. So without further ado, I will introduce Ruth Ann Norton, who will share her perspective on housing and health.
Fantastic. How's everybody? Good. You can hear me without a microphone, right? You need it. Oh my goodness. But since you can tell I'm a nurse, I followed orders.
Thank you.
Save the day. Right?
Outstanding.
There you go. And I got to stand when I talk. I don't know what that's all about, but so did everybody like that lunchtime speaker? He was pretty good, right? Anybody notice where he talked about they tried to ban go-go music on the streets in Washington, D.C.? So it reminded me of something. I don't know why I feel like I need to share this, but I'm going to share it anyhow because I saw it and it makes me think of my friend Chuck Brown, who is no longer with us, but Chuck Brown founded go-go music. And Chuck Brown and I were inducted into the Reginald Lewis African American History Museum on the same day.
Cut it off.
No sound. Okay.
Push it all the way up.
He's making me do something else. Okay.
There you go.
So anyhow, it made me think of Chuck Brown. So sending good thoughts to Chuck Brown. As he and I, and actually Ben Carson, were inducted into the museum on the same night. That was before I knew about Ben Carson's politics, so I won't say anything more about that. But it was, my staff thought it was finally cool because I got inducted with the father of go-go music into the museum. So it made me feel a little bit cool on that. But what I am doing, and everywhere I speak through October, is I am taking 1 minute to remember a very close friend of mine who just passed away. And you may have heard of him, Elijah Cummings. But Elijah Cummings was one of my partners who convinced me to do the work that I'm doing. He was my biggest supporter in 1993 when I started to take on lead poisoning in Baltimore, when we had 65,000 kids being poisoned a year in the Baltimore City, Baltimore County footprint, and walked with me through the neighborhoods in Baltimore, along with a friend by the name of Clint Bamberger. And I think Elijah, who at the time was the Speaker of the House in the state of Maryland, and I were struck by the fact that the condition of asthma, the condition of lead poisoning, and the condition of perpetually fleeing bad housing was normalized in the neighborhoods in our community. And I just want to give him a shout out. We lifted him up last Friday. But there are good people doing work at every level. So if you are sending good thoughts in good ways, remember Elijah this month. He did a lot for our country and standing up for democracy. And so I told his wife that I was going to honor him no matter where I went in the United States for the next month. A little bit about us. Sharon Hyde actually works here in Memphis for us as an outcome broker. That means we expect results to improve the health of housing in Memphis. and across the country. We were founded by 9 parents whose kids were seriously poisoned by lead in 1986, and they found themselves meeting each other in the intensive care unit at Hopkins Hospital. The tragedy beyond the fact, and there's no tragedy beyond the poisoning that happened for those kids, but that they lived literally behind the hospital. And what it represented for us was the twin tragedies of deteriorated housing stock and its impact on health. And so they set out in 1986 a mission that we've been on, which is to change that narrative, to look at housing as an opportunity for health, housing as an opportunity for a trajectory of better school performance, of better opportunities to age well in place, doing a little bit of support of that work of Habitat here in Memphis, and an opportunity for parents to get to work better because their kids aren't languishing in the emergency room. So let me just tell you that we live in this world of taking on here and about 60 communities across the country, taking on this issue of challenging housing around energy efficiency, which is a major challenge here in Memphis, asthma issues that come from extreme heat, extreme cold, but also mold, mildew, and moisture issues and pest management issues. Number one reason kids miss school, that is enough to say that we must understand housing is so critically important for where kids put their heads down at night, not to mention what happens if we don't do it for lead, right? And I'm not sure exactly where these slides are going to go. I'll give Sharon credit for all the slides, and I'll take risk of not following them really well. But think about this as we think about lead, and we think about the expanding budgets. I'm very proud of our organization because we have gotten, with Ben Carson in office, but in the current Congress, we have taken the lead budget in the United States from 150 million to almost 300 million a year. We want to go, there you go, you're the recipient of that, right? But we are aiming to go 500 million next year, and we have a bill in Congress to take it to 12.5 billion for 2.5 billion a year, because we are intent on ending this. We're intent on eliminating these issues of housing condition. That money also helps to address asthma. But we want to get out of the vortex of parents going to the emergency room and not being able to get to work because their kids don't sleep through the night, that they don't perform as well in school. If we want to change the narrative on equity, right? We now talk about our organization as advancing the social determinants of health and racial equity through better housing. And if we want to address those issues in a meaningful way, we have to assure that where a kid lays their head down at night is improving their performance in school. It's a starter block that cannot be, that we have to meet to level a playing field. But we're also looking at injury issues in housing and how they impact people like me, older adults, right? And how well we will age in place, how we will have an opportunity to pass our wealth, whatever it may be, and as modest or as much as it may be, onto the next generation. And I know from personal experience, having put my mother into assisted living, everything she had got wiped out in that process. Everything she got wiped out. So I'm a kid who inherited $500, right, when my parents passed away, and that's fine because we got to earn it on our own. But if we want to change generational wealth, community equity, we certainly can't be wiping it out. The things that we're trying to change by addressing that $155 billion of avoidable cost paid by Medicaid and Medicare every year on just those 3 issues, energy efficiency, injury, asthma, 4 issues in lead. And we don't have a dollar figure around energy efficiency per se in that, except for that it is the biggest depleter of wealth on a monthly basis in America for many families. That and prescription drugs, right? And we can change the narrative by housing intervention. And so we look at all of this as the social determinants of health. Let me ask you a question quickly. Besides the good doctor, is anyone here from a health agency? Next year, at this conference, I urge you, and I will work with you, to get our partners in managed care, to get 10 Care here, right? Our hospitals here, and I'm going to talk to you about why. But one of the biggest avenues that we have, besides trying to continue to raise budgets and to get private investment to contribute to low-income housing, repair, remediation for occupied housing, the biggest aspect of poor health out of housing in America, is that there is an opportunity now that we are moving these social determinants of health. Every Medicaid agency in the country is on an urgent fire drill to do this. And I know this particularly about Tennessee, because last week I met with 10 Care about proposals to do pilots to improve health. Now, I was there with people from Chattanooga. Love the people in Chattanooga. But wherever Paul Young is, he knows I love Memphis, right? And we need to be putting these proposals in about payment innovation, about how do we help your state Medicaid program advance the social terms of health through housing, and the highest costs that they are bearing are coming from asthma and injury for kids. So something we need to look at in those outcomes, right? And this issue of energy efficiency as a way to improve stability and health. We got into the field of adding energy efficiency to our work of lead and asthma because we were making houses lead safe in Maryland. We were reducing asthmagens. We were keeping kids from getting burned from radiators. We were fixing structural defects for injury. And families were still moving because we didn't address the energy cost. When we started to do it, we thought, great. We will start to have that marginal wealth put back in, right, by lowering cost. But what we found is the profound impact on asthma. And some of the best studies in the world on this, or in the nation, have been done from Oak Ridge National Labs here. The other thing that we're trying to do is in this cycle, which is families hunting and pecking for 18 different ways to improve their house by going to different agencies, right? And we should care about this in social services a lot. When we studied this impact on our families on our direct service program in Baltimore, our families who were intent on lowering the pest issues, pulling up the bad carpets that were causing asthma, fixing the moisture control issues, fixing leaky roofs, replacing windows, getting the lead paint out, right? So they would breathe easier, they would be able, their brains would be healthier, they wouldn't be injured. They were missing sometimes up to 23 days of time to chase applications, to meet inspectors, to meet contractors. That's 23 days of time of missed work for families who we are saying what? Go work, keep a job. I'm the president and CEO of my organization, been there almost 27 years. If I miss 23 days of time in addition to everything else, they probably say, hey, see you later, right? And so we've got to solve for this problem. So one of the things we are working on to solve in this is to better align programs at the local, state, and federal level to even out and get away from this multiple way of qualifications and asking people different qualifications, but to streamline that to a standard set of qualifications. Now we promote a model of integrated assessment, comprehensive assessment. This guy on the slide is Hector Moreno. He's kind of a cool guy. But he wrote a comprehensive health and housing assessment form that we now have adopted in 4 states. And in my own state of Maryland, it's a required comprehensive assessment that you must look at resident health and the health of housing before applying for any use of state funds. We do that because we are looking to make healthcare a partner in this as well. And we want to track those things that are causing health impacts and the outcomes on that. So we do assessment and education along with intervention in our own direct service program. And out of that work of being able to align it, we are also promoting workforce development of contractors who are multi-trained to do this work, right? And so this is some of our partners here in Memphis that we are working on how do we cross-train contractors to do this. I know Habitat's trained and doing it probably well as others are. What we know from a study from the Center for Employment Opportunities when we looked at this in our work in Buffalo is that we raised base wages $4 to $8 an hour for workers because they became more valuable in their work by being cross-trained, but they also became more effective and more efficient and will help governments save money by being able to accomplish more in less hours. And so you get a win by raising wages and lowering the overall cost, and I think that gets to a betterment for everyone in this, right? And so some of our partners, we're working with TVA on this, and the folks in Chattanooga, here in Memphis and through the Urban League to promote a workforce development strategy. Sharon can say all about all of this, but it's both hard skills and soft skills to advance this. Again, something, by the way, that healthcare cares about is advancing workforce development. So as you think about talking to them more about this, and we are looking at this as a whole house strategy. Don't walk away knowing you haven't finished a job. Know what it's going to take to get that house to par for help and bring the resources in. First of all, families don't want us there 10 times, right? We want to get it done. It's more cost effective. You can track better what the outcomes are and be able to better utilize money. I'll just tell you quickly, these are 3 studies. We're about to release another set of new studies, but these are baseline studies on which both National Institutes of Health and CDC are now basing new criteria in their guidelines. We proved that through 3 Healthy Home Tech studies that we were able to dramatically lower hospitalizations, dramatically lower emergency department visits, improve school attendance, improve work attendance. Hang on to that, because I want to talk to you about this pitch that I hope all of you make to Tenure, to United, to Blue Cross, and to America, your 3 managed care organizations that are here, right? We're also working with the CHAMP program, one of the best asthma programs in the country, to try and improve direct reimbursement by these managed care organizations into the work that CHAMP is doing, but extend the work into root cause remediation of the factors that are happening. So you can do, let me just quickly, I got you. We can do education and we can give asthma supplies, but unless we fix the things that are exacerbating asthma, it just is a hamster wheel of going back and back and back to the healthcare system. With intergenerational families, we have lots of opportunities for healthy housing to do small and sometimes larger interventions in housing that will prevent injuries, will allow older adults to age in place, but everybody benefits from it. But think about the fact that aging in place not only saves money, it improves socialization for families to be able to do this, it keeps families together, and older adults who live in their homes for longer periods of time in housing that is safer will live longer, period, with a higher quality of life and not in a lower, more costly quality. So we're doing some evaluation work with Habitat to look at how do we go beyond educational and kind of an occupational therapist working with families, which is the Capable program, a great program that's also out of Baltimore, and actually look at the structural needs that are needed in housing. And by doing that, we also build better housing stock up and strengthen it for the neighborhood over the long term. So I won't go through a bunch of this. I just want to get to a couple of quick things, and then we get to, I can tell you all about family stories and savings and important things. But I want you, as folks working in housing, to think about a couple of things. The Children's Health Insurance Program, everybody know what that is? Right, created by Hillary Clinton when she was a senator, but it helps with kids above Medicaid, but still low-income kids. Every state in the country gets 10% of their CHIP dollars as administrative dollars. Most states use about 3% of administrative dollars, which means there's about 7% of their administrative money sitting on the books unused that goes back to the US Treasury every year. So what states have started to do is to draw down those monies, which they are entitled to, at a high match. You can do social services out of this work, you can do health out of this work. The match currently is 88% paid by the feds and 12% paid by the state. So we have drawn it down in Michigan, Maryland, Indiana, Ohio. We're getting ready to do it in New York State and Pennsylvania. And we've used it for lead, hazard control, lead service line replacement, if you're interested in the lead and water issues. We've also used it for asthma. And it is money that is there for your state and can be drawn down. Hospital community benefit is dollars for every nonprofit hospital. They're required to be investing in community, investing in housing repair and remediation and advancement is a big deal for housing community benefit dollars today, and I'll look at them very quickly. And we've been looking at other ways of managed care to come in to this, so I want to give you just a couple of quick examples of that. This is just to tell you about the business case for lead. Every dollar invested, up to $221 return. I'll take that. There's no stock market. Nobody who brags about it, whether they should or shouldn't, can meet this, right? And there's asthma is the same as a high return, right? But I want to talk to you just about this role of anchor institutions, in addition to talking to Medicaid and managed care. Because on Medicaid and managed care, what you are helping them do is reach their outcomes they are now required to meet. Lower hospitalizations, lower ED visits, get kids in school, increase the access to work, housing stability, economic mobility. All of those things are part of the social determinants that both Medicaid and managed care have to have in their work. But anchor institutions, nonprofit hospitals, I want to give you a couple of quick examples. I'm currently working on an operational plan for Lancaster General Hospital, part of the University of Pennsylvania Medicine System. Their goal? They are going to de-lead and make healthy every home in Lancaster County, Pennsylvania. That's 600,000 people. It's not the biggest place in the world, but this is a hospital board of trustees when they were faced last year with making a decision for the next decade of investment of what they were going to do with community benefit dollars. They looked at homelessness, they looked at diabetes, they looked at a whole bunch of things. And they decided to invest in lead poisoning prevention, for which actually it doesn't cost a lot in the healthcare system early for lead, because there's no cure, there's no real treatment other than keeping kids from dying. You can't reverse this. The health effects come later when it's increased hypertension, increased cardiac arrest, early mortality. But they still said it's neurological impact, it's about the quality of life, and if you do it, you're going to improve other factors. So we're looking at a huge investment. Huge. Just think lots of dollar figures. I'm not allowed to tell you the dollar figure on this until they announce it in January. But they are getting this point and want to become a national model. Boston Medical Center put in $6.5 million to reduce asthma in their community. And at Hopkins, we are working on a program called Breathe Easy, where we're going to do 1,500 households of kids missing school for asthma, inspect, repair their homes for asthmagens, get 1,500 kids going to school better. So talk to your hospitals, and talk to your managed care. AmeriGroup in Baltimore and then soon in Iowa are reimbursing healthy housing improvements, housing improvements. And so these are important things to look at. We're doing some other things. I want to just, we have a national lead campaign really quickly to tell you that we're working on. Sorry, I don't know where I went here. Hold on. There you go. Important aspects of trying to lower lead. Our biggest agenda there is to stop the sale of leaded housing by the federal government back to communities. All right, but we're also writing strategic plans. We have a bill in Congress that Mr. Cummings was the sponsor of. We'll get a new sponsor that is looking to take 2% net of opportunity zone investments and put it back to lead and healthy housing programs across the country. We're doing strategic plans on this issue. We wrote a strategic plan for the governor of New Jersey. And last week, 2 weeks ago, he announced a $500 million investment in the state of New Jersey to reduce lead. And we're working on a $1.1 billion investment for the state of Michigan. So these things can be done. All comes from community. So let me stop there, turn it over to my good friend here. But just to end with this, was we think about important ways of how you craft what you do in the future. We've reduced lead by 98% in the state of Maryland. We did that over a 12-year span. It actually just went down another 11%, but on the whole scale of things, because getting us close to 99. But that 98% reduction returned $44.5 billion back to our state. Here's the problem with that. When we structured how we did this early on, our only goal was to lower lead poisoning. Awesome goal. What we didn't do that I would change today is ensuring that every dollar that was invested and got tagged as a benefit would get reinvested in the communities that have paid the price for generations. So we're rethinking how we structure housing to do that. Because my kids in Baltimore, my family's in Baltimore, my neighbors, my friends, the people I go to church with, right? They deserve the $44.5 billion to come back to them in educational benefits and better housing and better communities. So we can do better about how we structure every contract of what we do to ensure that the investment goes back to the communities we need to lift. Happy to talk about that, and thank you.
I'm going to stand. I'll go ahead and sit. And while I had some questions I was supposed to respond to, I think what I'll do is kind of build on some of the things that Ruth Ann has said, starting a little bit around my background, so you know what I bring to my role as the Director of Health in Shelby County. And then some of the other health issues that we face here that we know are related to housing. And then some of the things that are on the horizon, including partnerships and most recently a joint community health needs assessment. So I'll end with that, and we really want to open it up for conversation and dialogue. So I am a nurse. My background is I actually grew up in the inner city of Pittsburgh, and the importance of that is I grew up in a house that was over 100 years old. It was a Victorian row house, had all the issues that she's talking about in Baltimore. And then in moving to the South, I spent over 30 years in Nashville as a public health nurse, but the majority of that time was as a visiting nurse. So I can tell you the number of patients who were admitted to the hospital for congestive heart failure only because they didn't have an air conditioner. The number of people who experienced falls that never were able to return home as a result of the housing conditions that they lived in. But I actually left public health. I retired and went to the private sector post ACA. And a lot of what Ruth Ann is referencing as more recent opportunities to leverage anchor institutions and to be able to petition or advocate to insurance industries to fund this type of work is always a result of the ACA. We think about insurance and access to insurance, but much of the work from the federal level down was to focus on prevention and to address social determinants. So I went to the private sector, to Delaware, which is not far from where Ruth Ann is, and worked at Nemours Pediatric Health System, which is associated with the DuPont Foundation. And we led a program very much similar to CHAMP. but not only an emphasis on healthy housing, but healthy daycares, healthy schools, and other community-based organizations where children are served. Within the first quarter of a 2-year award, we had reduced our emergency room visits by over half. And that just continued to get better as far as return on investment. Where we were not successful, which is why we need organizations like GHHI, is getting the insurance industry to change their payment model. It was a little bit hard also for, I hate to say this, for some physicians to be open to the fact that it was better to prevent children from coming in because they were still on a fee-for-service basis and they made their money based on that. But I decided to come back to public service, so it brought me to my role here in Shelby County. As the health director, one of our priorities is healthy environments overall, and that includes healthy housing. I think in my role, I do have an opportunity to speak to the intersection of health and housing, and it's my responsibility to do that as a public health leader. There are some health issues that we know locally that are relevant to our housing condition that Ruth Ann didn't mention, so I'm not going to repeat what she's already talked about. I think most of you in the room know we have a very high infant mortality rate. It has gone down significantly over a decade because of partnerships. But what we do know is that co-sleeping is still a significant contributing factor to sudden infant death. And while we give out pack and plays and we assure that there's separate bedding, many of the homes do not have sufficient space to actually put the pack and play up. And so overcrowding or multiple generations living in one household because they don't have affordable housing options actually contributes to our infant mortality rate here. The other is because we're in the South, and we have mold and other things that Ruth Ann mentioned, we also have those mosquitoes that all of you know about and hear me talk about on TV every summer. But the lack of screens and other things, that is what can contribute to transmission of things like Zika. And we were very fortunate here when we had Zika cases to not have a large outbreak. That's in part because we quarantined people or asked for voluntary isolation. But I'll point to Miami, where the Zika cases went fairly quickly in inner city urban areas, particularly where there were lack of screens. So those are some other things that are relevant here to us. Some things that are on the horizon that I think are important is, again, Ruth Ann mentioned the anchor institutions. So all of the nonprofit hospitals are required to do a community health needs assessment and set priorities for the health of the community, and then they determine how they're going to use that money to improve health outcomes. Historically, across the U.S., organizations have done those individually. And so you have what I'll say is somewhat a lot of waste, because you have one hospital does a needs assessment, another hospital, and there may or may not be overlap. So over the last year and a half, the health department worked closely with Methodist Le Bonheur, Baptist, as well as Regional 1, and St. Jude's as well, and did more of a collaborative community health needs assessment. Now that may not seem like a lot, but it is a lot if we can say child health is a critical component that we all agree we have to focus our resources on. Another piece that is aligned with that is the mayor leads the Healthy Shelby initiative. And historically, that focus under Mayor Luttrell was more on what I would say health care type activities. With Mayor Harris, our focus has been more on healthy eating, active living, and mental wellness, but we're actually looking to add the environmental piece. So that is how the community health needs assessment drives bigger initiatives, and those are important. I think will make a difference long term. Our role in public health, one is to elevate this as a serious issue and continue to talk about the intersection of health and housing, but we also have a traditional role of screening for lead. It's really been our body of work for over 25 years, and while we've seen some reductions, they're not sufficient. And then we can't do everything alone, so we have to partner with others, including the city of Memphis and many of you in the room. I actually was saying hello to many people and said, I'm going to be speaking to like-minded people, so you may not have any new takeaways. But many of you are partners, and so it's our opportunity to leverage those partnerships to make a difference. One of the places, though, in public health that we do have limits needs, and I think it's important to point that out. We, again, rely on organizations like GHHI to do advocacy work and lobbying at the federal level. Many of our organizations locally that receive federal funds are actually prohibited from doing lobbying. So it's important that we partner with others who have the ability to do that on our behalf and then work to set a common agenda so that we can establish policies that benefit the children that we serve and the families that we serve across the lifespan. So I'm going to pause there because I know the moderator had some questions, but we really want the audience to ask some questions.
Yes, and, yep. Thank you. We'll just open it up to questions from y'all.
No question.
So,
Go ahead.
I was just going to ask, so there's many homes in Memphis that need this kind of work, this environmental energy efficiency, lead abatement. So I guess I'm wondering how you, when you've been starting to do this work, how do you prioritize where to start? Is it just people who come to you, or is there kind of more proactive ways that you're trying to find the houses that need this type of work and get to them?
I'll speak then ask Ruth Ann to add to that. From the public health perspective, because we do screening for lead, that's how we're going to prioritize is those children that we know actually have been exposed. But what else happens in public health, and this has been historic, is that if you start to see clusters, then you have to proactively ask for change. And some of that has to do with public housing that was torn down years ago. That actually was because public health spoke up and said, you know, you have a cluster of children being lead poisoned here, and it's in the environment. So we do both. But in an ideal world, there needs to be more resources so that we can be more proactive and not, you know, we focus on things like lead poisoning because that's critical for children, but we also have to focus on our aging population. To have someone age in place and be able to stay at home, as was already mentioned, it's not just their physical well-being, but their mental well-being, but also that intergenerational relationships that occur, so it's really important if we can keep our seniors home, and that needs to be more proactive work. And there's work being done, but I would say it's not enough.
So, thank you. So I think fundamentally, what we kind of have is a no wrong door mentality. And so if you can come to a platform where you can do a comprehensive assessment, right, then if you are coordinating at a high level the home visiting work that's being done, and any number of issues can trigger that comprehensive assessment and that scope by which you can then try to work to break those resources. That is actually the ultimate goal of how do you address this. And I think this cross-training is so critically important because if you're going to address an energy issue, there needs to be a question about whether there's someone with asthma in the home, the age of folks that are there. You will find probably very often in poorly weatherized housing, for example, a high rate of respiratory illness. And that goes from cradle to grave, right? So the doctor was talking about the fact that, you know, respiratory illness in homes that didn't have air conditioning or proper heating and cooling landed up with heart failure and other issues that happen there, right? So all of these have an interplay. And I don't know that you can say we're going to start only with lead poisoning or the like. Now let me be somewhat provocative with my friend to say that lead screening is critically important, and we're always too late when we screen for lead. Any level above 2, right? We likely are having cognitive damage. So, and I was on the panel that got the federal government for once to put a policy together that said there's no safe level. We lowered the threshold level for action, right, in this country. But screening is critically important, and we need to get to those households so no one else gets poisoned. Kids are mobile. They go in lots of places. We have to look at the entire housing stock, not just where kids are, but where they may visit or where they move to. the drive for us to get these resources up, right? So we've doubled them, and now we're trying to go to the next level on that, is that we have to be preventive. So when you are at a home for any number of reasons, if there's chipping, peeling, flaking, paint, the city of Memphis is now going to be equipped a little bit better to get ahead of that problem instead of just chasing poison kids. We're starting to change that federal criteria that says be preventive. It used to be we had to spend 90% of our money on only poison kids and 10%, if I recall, right, on prevention. We have to flip that if we want to change the trajectory for kids. So.
One of the opportunities locally that I didn't mention, and I'm remiss in doing that, is many of you are familiar with the United Way Driving the Dream. And the intent of that is a no wrong door approach, that when an individual or family is being served, then all of their needs are identified and there's a systematic way to do referral. Clearly we need more people engaged in that system, but we also need to look at how do we share information more comfortably between organizations. And that's a conversation we can have locally outside of here, but that is really a critical piece so that families don't have to keep going to different places to try to get services.
When you said driving the dream, I thought it was Penny Hardaway driving down the paint.
Everything you talked about, some of the opportunities around chip dollars, et cetera, and so on. Anything that GHHI or other partner organizations are looking at in terms of a Tennessee specific?
Yeah, so that was the meeting.
Advocacy.
That was the meeting at TennCare last week. You have a great person in charge of payment innovation. It was, I think, Jennifer, but I'm happy to share her name because I know that she is seeking community solutions to look at, and TennCare just closed the comment period, so we put in a lot of comments around how do we do some of these things. So one of the things that we're following up with them on is can they pull down these this health savings initiative dollars? And the state will have to put up money for that, or they can find creative ways to do it. So one of the things that we talked to them about is we got it done in Maryland. And Maryland didn't want to put up the match money itself. But we had a contract with the state to do lots of different things that were aligned with the request. So I said, take our contract and put it in the proposal as match, and we will better align our work to support the pull down of this money. And that worked. So there are ways to get that match without having to go necessarily find new money, but you may be able to move it differently, right? So I think there's opportunities there. I think there's plenty of opportunities around injury, around asthma, around lead, and I think also around indoor air quality to do that. There's also something that you all ought to think about. Yesterday, there was a federal initiative announced its first round of awards in a thing called CIPRA, Social Impact for Performance. And it took programs from around the country. Some of them were supportive housing, some were early childhood trauma, some were different types of housing work. And it will be coming up on another round of funding where if you can prove that you are saving federal dollars of any kind, not only health, housing, energy, labor, right? Justice. If the work you're doing, you can map to federal dollars that would be saved because you're going to prevent something or improve it, that program pays the federal outcome savings back. So it allows you to borrow from a bank or foundation or a high net worth investor or whatever. It's not requiring any kind of state, I mean, the state doesn't have to put anything out, your local community doesn't have to, can, right? They could say, okay, if you save the dollars, we're also coming in. But we're going to be putting in one for a couple of communities next round on asthma. But that's an opportunity I'm happy to share with you that allows you to get a model, use the federal savings to come back and reinvest. In New York State, we're getting ready to launch a multi-agency program that's going to do its health, housing, and the environment, or energy administration. And for the first 2 years, they're going to fund this grant program. In the third year, managed care is going to pay it back. So we are advocating to United AmeriGroup across, both in Chattanooga and across the state, on why they need to be moving the needle, but it takes groundwork from others than just us, right? As much as we love Sharon, we're not a strong enough presence as a Tennessee organization. We do have an employee in Knoxville, so that makes 2. And I threaten to move to Memphis all the time, so that makes 2.1. But I'm too much trouble, you don't want me in Memphis. But so there's that piece of it, right? And then I think there's a number of other things that we're working on, and happy to talk to you about offline. And we're happy to help lift up other efforts around this. So part of the work we do is to go into communities and go underneath and build up and lift up. So happy to do that.
I'm just gonna add a comment, because I think we have to, but also reinforcing that it needs more people at the table. So the conversations with the payers at this time, particularly around asthma, bundled payments and so on, you have to look at how long La Bonheur has been doing the champ work. And so we've got to have what I would say more revolutionary change in the payment system. It's got to happen quicker, because the evidence is there that we're going to save on healthcare dollars by doing things differently. But the payers have to switch a lot more quickly. So again, we need others who help with the advocacy work to help make that happen much more quicker than it has thus far.
Documented family stories really matter, and then the evidence can come behind it. In the AmeriGroup work we're doing in Baltimore, they started funding us because we were saving them $3,000 every 6 months per patient per month, $700 some per patient per month. So it became a point that they no longer could say we shouldn't be doing this. It was in their best interest, and they get to keep it. Now they're funding it out of administrative dollars. But what I think is really important for this crowd, right, for all of us, is get the translation of what it all means. And many of you may be way better than I am at it, but those who aren't need to learn the vernacular of the healthcare side to be able to start to talk there. We have to have a lot of push on what we know and what is real. And we have to have some understanding of what the culture change means to folks, right? To say we should move from volume to value, right? Move kids and families out of the hospital and out, right, to better care preventively is great. But for the chief financial officer, that it's panic, right? And they're trying, and so we have a lot of therapy and a lot of socialization to happen there. And I would say that to my best friends in healthcare. But I think we will. We've seen a lot of change, right? And we now have 10 sites around the country where we have managed care funding at least a part of Healthy Homes programs, and that is it's a small revolution that can tip a mountain eventually, and that's what we're heading to try and do.
Yeah, just I had a question from a fair housing perspective, and that is in regards to the Massachusetts model, which I don't know a lot about and would welcome your input, but my general understanding is that there's a requirement that landlords that rent to children remediate their homes or face the liability that the kids who get poisoned living in their homes might experience. And from what I understand, that model has failed because landlords just don't rent to children. And so, one, it's meant that there hasn't been the remediation that it was intended, and two, it's meant that families with children haven't been able to find housing in Massachusetts. And I ask in part because I understand that some of the federal legislation that's been proposed has applied a similar proposed model rather than targeting affected areas with resources and phasing in those changes, but a similar kind of mandate has been proposed.
So I can tell you that we passed the Maryland law, our lead hazard reduction law was for all pre-78 rental housing and not where kids live. If you have a law that says you have to clean up only where a child is living, there will be Federal Fair Housing Act violations left, right, and center. It's a basis for discrimination, period. And that's the failure in the Massachusetts approach. They have changed it
In Massachusetts or in the federal proposal?
in Massachusetts. And we are changing it in the federal elections, right? We're starting to change it a lot. The lead program here in Memphis that just got an award, right? That it is starting to change to say do prevention in pre-78 housing. And what we did there a long time ago, which we're trying to move even more, is we got it down to if a child passes through a unit even 8 hours a month, it'll qualify. That's the federal threshold that they will be okay with. We're now trying to move that out entirely and say you must clean up all housing stock. And I would look to see that that change is going to happen relatively soon. It's got a lot of support, both Republican and Democrat, to do that. But no program should be predicated on kids only under 6, because I'm telling you, it's an open invitation for problems. Sorry, we had other questions. We have 5 minutes.
I was just wondering about, you were talking about aligning the federal, state, and local laws. In many cases, we would get information or we would get opportunities for funding on the federal level, but we didn't have necessarily the local and state enabling legislation. How difficult has that been for trying to get states to and local municipalities to come on board?
And excuse me, I'm a state here, and at my ripe old age of 59, I just took on a trainer, and so my back is killing me because the 39 years prior to that, I don't know what I was doing. But my back is asking me the same question. So my apologies for that. So I was talking about aligning criteria for grants, right? There is a little bit of a difference of aligning the laws. But aligning the criteria of asking families all these different qualifications is just dumb and dumber as far as I'm concerned. If your kid's on WIC and you're on Medicaid, holy cow. Do you really have to go jump through that hoop again to go reprove that you are poor? What are we doing? I mean, we beat up on poor people. Okay, we all know that, right? The alignment sometimes of federal, getting states and cities to get in line with things they ought to get in line with, I have to tell you, I'm sometimes a fan of that. So one of the proposals we have on our federal lead strategy is to say, if you want to receive money from HUD, then you need to have a prevention program that has environmental intervention at 5 and be acting upon that as a state. Now, I don't know whether or not that causes any heart failure. I don't think it will, but we want to push, right, but we want to push state legislatures to say, you want money to do the right thing to ensure that when the money gets to where it needs to go, it can get to where it needs to go, right? So I'm a big fan of kind of using the bully pulpit when necessary, but not leaving people on an island. The risk of that strategy is, in Mississippi, they may never do it, and kids will never get resources, and so having a period of time or do it. It's on us as advocates to do that. I call it public education, others may call it lobbying, to change hearts and minds. And I think what we have in the work that we do is we're able to prove that we will save healthcare dollars, we will save Medicaid dollars if it's really looked at, we will improve communities. And so it may be, is Brian still I'm going to pick on him, the governor of Mississippi, he's still the governor right now? So anyhow, I sat at the table with him one time, he told me that he loved me, it made me a little nervous. And because I wanted to lower his Medicaid budget. And I said, well, that's great if you agree with me on that, but what I want to do is protect children and get money for children where they need to go. So we may have two different views of where but we get to the same place. But that's a really tough, and that's a long question over a glass of wine. supposed to wrap up. I think you're the wrap-up part.
She's going back to Baltimore, we are not. So really, the responsibility
I never leave Memphis. Come
is on us. I know where your office is in Baltimore. So really, the onus is on us to do things differently and to come together in a way that we're going to make an impact, not just for children, but for all people. And it was said earlier, but I do think that the bigger issue here is an equity conversation. And how do we assure that everyone in Shelby County has an equal opportunity to reach their fullest potential? And we all have a part in that. So that might be a wrap up, but I would say it's really a challenge.
If you're on Twitter, follow us on Twitter. This is a paid announcement I'm required to do.